Alors, bonjour tout le monde, bienvenue. Vous êtes toujours déjà à votre place, vous êtes très disciplinés ce matin. Je suis Antonia Maioni, je suis présidente de la Fédération des sciences humaines et je suis ravie de vous voir en si grand nombre aujourd'hui même. We're so very glad to welcome you here to the Parliamentary Restaurant this morning. I'd like, on behalf of the Federation, to extend my deepest sympathy to many of you who work, sometimes probably feel that you live in this building in light of the events that took place here last Wednesday. And I'd like to say a special thank you to James Rajat, our MP sponsor for the Breakfast on the Hill Big Thinking lecture series, and also for allowing us to be back in the Parliamentary Restaurant so soon after last Wednesday. Thank you very much. It's my very great pleasure to introduce Bartha Knoppers, our speaker for today. Bartha is one of our most distinguished colleagues at McGill University, and where she is director of the Center on Genomics and Policy in the Department of Human Genetics at the Faculty of Medicine, and also Canada Research Chair in Law and Medicine. Bartha will discuss today the collection and implementation of big data and the important impact that this has and will continue to have on our healthcare system. The reason that Bartha's talk is so important and also so anchored in what we do as a federation is that this Big Thinking lecture series tries, in a sense, to do what Bartha does, to take research from the social sciences and humanities and bring it to those people who can use it to inform decisions about policies that affect the lives of Canadians. In that regard, I would also like to thank the Social Sciences and Humanities Research Council for their continued support of this series. And they, I think, have a newsletter that you can pick up at the registration table before you leave. In addition, today, due to the nature of Bartha Knoppers' talk, we're especially pleased to have partnered with Genome Canada. And again, Genome Canada is one of those organizations that connects ideas and people across public and private sectors to find uses, new uses for genomics that translate into applications that can benefit all Canadians. Mesdames, Messieurs, voulez-vous me rejoindre en accueillant Dr. Bartha Knoppers?
Bonjour, good morning. It's been quite a while since I've done what used to be called Breakfast on the Hill. It's an honor to be back here again, and I join Antonia in saying I was particularly pleased to be able to walk up past the flame this morning and feel, as a Canadian in our social, open, democratic society, to still be able to participate in this event. Excuse me. The original title of my presentation was about big data. And then someone said, well, no, you've got to make it more practical. Don't go into one of your professorial, big thinking things. What does it really mean for Canadians? And so I decided to concentrate on our healthcare system. So I'll start a bit about where big data comes from and then look at its first impact in terms of populations and subpopulations, and then go to the ethical legal challenges, which I think is why I was invited here, and then conclude with some forward-looking, hopefully, some forward-looking thoughts. So everyone imagines, like myself, I'm a social scientist. I'm not an astrophysicist or a mathematician or a geneticist, even though I'm now in the faculty of genetics. And what is it? Is it just a lot of small data put together? And is it the volume of it? Is it the fact that big data allows us to actually begin to see patterns or to extract via analysis in the clouds, in cloud computing, to extract an understanding of what is happening by the fact of the sheer ability to handle this data, to compute this data, and to understand it. So how does it work? Well, first of all, it's the new raw material of today. And because it's raw material, like other resources such as water and so on, we need to handle with care. And I think that's probably going to be my conclusion as well. And because it's exciting and the possibilities are endless, and the bioengineers and the artificial intelligence people and the computer geeks and everyone are trying to work as fast as they can to manipulate the data, to be able to compute it, to be able to use it, we have to pay particular attention so that it doesn't actually eventually cause problems that we could have foreseen and prepared for. So I have a few maps here because the theme behind all of this is networking and collaboration, because you can only have big data if you work together, both at a systems level, but also at a human and societal level. So this is a map. I called up the cartographer and asked if he had an update. These are scientific collaborations 2005, 2009. And since that time, there have been new projects such as H3 Africa, Malaria Gen, and I think you'd start seeing other parts of the world light up. But this just shows you that networking in science is extremely important and probably will move away from the sole single genius innovator. We still need them. Hopefully they'll continue to exist. But think more of actually teams across the world. These are where anyone who's able to connect to the internet, again, another map. This is from August 2014. And you can see, again, there are disparities, but you can see, again, the connectedness and the ability to share data. This is my favorite one. It comes from an Italian researcher called Bartha, who actually is able to show the links between diseases. So one gene, wherever there's a line, it's linked between different diseases. And this is interesting because our research institutes go by organs and body parts. Our hospital floors go, here for legs, over there for wombs, and over there for brains. And actually, we might need a new taxonomy since diseases are no longer sort of neatly separated, or we can't even understand them if we don't understand how they are linked to other conditions. So this is really important for the future of science, that specialists might have to become generalists. And finally, just to get closer to our subject matter at hand, you can see in the bottom those awful needles and pills and things like that. But what really determines health or resistance to disease or susceptibility or even predictability, many more factors than genes and your family history. Geospatial factors, your environment, where you live, public transport, fresh produce, the amount of time you spend in airplanes, like myself, very prone to all kinds of chest things from the air, the climate, obviously, and the use of electronics and so on and so on. So all of this actually fits into the data analytics that then feed in to a contextualization of the person vis-a-vis their health. It cannot be, your simple medical record. And for that, to be able to understand those influences, we need tons of data from everywhere. Still on my theme of collaboration, this was a study of 1.25 million scientific articles, just came out 3 weeks ago, and it showed that scientists, social scientists, pure scientists, bioengineers, IT people who collaborate in these new big research teams across the world actually have a higher chance of being published and being published in high-impact journals. So this collaboration is not just out of necessity to understand what is happening, but also actually leads to more scientific recognition. And I think that is a very positive result. So turning then to where are we with this big data, particularly in the area of genomics and genetics? Well, I have a hypothesis that once we understand populations, more or less, in this new sort of context, then we can understand subpopulations, what's called stratification, going down, targeting where we know people need prevention, or where we know they need treatment, or where we know that they are more at risk. And this is interesting because when you say stratification, and people think, ooh, that sounds like discrimination, or they somehow selecting out right away in our universal healthcare system seems like a dangerous thing to do. But again, part of my conclusion is that there will be no sustainability of our affordable, accessible, portable, very dear Canadian healthcare system, a shared value, if we don't target and put money and care and precise medicine, médecine prédictive, médecine de précision, right, due to stratification. And this is an example. It's a Canadian researcher from Quebec, Jacques Simard, who with 65 others actually were able to identify within the breast cancer domain specific populations at risk. Same thing for prostate cancer. So the more data we're able to put together, the more we can offer and move towards from populations to subpopulations to personalized medicine. Again, infrastructure science, biobanks are extremely important. You can have databases, but if you don't have the samples to verify, to validate toxicity, environmental influences, and so on, if you can't follow people over time by having access to their samples and checking every 10 years the impact and so on, you are not going to be able to do personalized medicine. So these biobanks, whether they're medical leftover samples or they're people participating, like in Cartagena in Quebec, it's a population study that I founded in 2007, you are not going to be able to understand disease or health. So what does this mean then for patients while we're on this stratification? Well, if we could use health records, medical records, take that data and look for patterns of what happens in hospital environments, in different communities and in different diseases, it would have a tremendous amount of not only cost savings, but better medicine, and would be more representative. Problem is that people select themselves in for research, and we need to have a broader database representing all different types of ethnicities, of age groups, and so on. And this, I think, the medical record, being that everyone who's a citizen can become a patient, or is a to-be patient, I think is more representative of the real risks and resistance in society. So any pure scientist in the room here, that's the extent of my knowledge base on the science itself. So let's turn then to what are the ethical, legal, and social issues. This is my slide from when I first started teaching in 1985, and I created a course on genetics, ethics, and law at the Faculty of Medicine at McGill. And I'm not so sure. If I look at our own children or anyone in the classroom today, or all the little Fitbits and data that's streaming all the time and the social media, I'm not so sure that we're as scared as we were in terms of what the role our genes play amongst other factors. But this is a slide that I really think illustrates well the constant fear that somehow any kind of genetic information is more dangerous or could be more harmful, and so on, and stigmatizing, etc. So if we are, or if we do need, or if we will be building large databases and population infrastructure biobanks, what are there real risks? One thing I can say, do not make policy based on hypothetical what if one day somewhere someone does. That's the worst thing. I mean, that's a kind of unethical trump card, because if you say we can't guarantee somebody might, then what kind of policy is that for people in real life when everything sort of gets shut down because of some imaginary problem? This does not mean that people cannot be found. I've been involved in some mapping efforts that are international, and if you are in a de-identified, anonymized, large database, but at the same time you're hooking up to Ancestry.com and putting in You're looking for your roots or whatever, plus you're participating in Twitter and social media, Facebook, and you're looking up, let's say you're a member of the Mormon church in Utah, you participate in a population biobank somewhere, and there's a sample in a fridge in a hospital, of course, you could be potentially re-identifiable. But that is no reason then to not build an infrastructure or have the accurate quality data that you need for medical care. Again, favorite thing, if I stop at the airport and they ask me what I'm doing, and I always think, oh dear, what do I say? If I say law professor, which I am, they'll say, what kind of law? And then if I say biotechnology, ethics, they'll go, cloning. And then, okay, yes. And they say Dolly, and then they go on, and or Gattaca. And that is really more the younger generation. The idea that having all this data and being able to determine patterns, you can never determine health or death or whatever, but that itself will create different classes. Actually, what big data allows us to do is to really mess things up. That traditional categories of discrimination, age, gender, ethnicity, and so on, when you can see patterns of risk and resistance, things start changing classes. In other words, you get regrouped into different categories of risk than the traditional ones. And so maybe if everyone is at risk for something or resistant and healthy as well, we always talk about disease, but there's health, we're all here, maybe then we'll get rid of this notion of labeling people because we'll belong to new communities that we never thought of risk and resistance that we didn't think we belonged to. So this is the bane of my existence. How do you explain all this in consent, whether it's for using samples after medical care or whether it's in a research project? It's terrible what's happening in consent. They look like notarized deeds, either your last will or you're buying a house. It makes absolutely no sense to try, to imagine. They're supposed to be consent forms. They're not supposed to be legal protection documents. And you get these standard clauses that I just keep putting X's through, and then the ethics committee keeps putting them back in, and so on and so on. Another real systemic issue, in addition to ethics committees and contradictory opinions on the same research protocol, is the inability to communicate. Only 14% of physicians can actually share their medical records electronically. This is, I can't imagine it, that we cannot do better than that. And this is we presume as patients that when our sample goes somewhere, that our GP will know, and our specialist in urology who's in the hospital across the street will also know. So to finish on the risks related to populations and so on, big data then will allow, if electronic medical records are standardized or at least harmonized, at least comparable, at least interoperable to some degree, that we will have a more representative medicine system here, a health system here in Canada. And patients are doing it. If you can read the small print, it talks about patients like me. They're just putting themselves online and saying, anybody out there who has this, what did you do? What drug did you get? Here's a picture. Pictures, you're not allowed to share them, image, privacy. And they're actually creating their own networks and throwing it out there. And the rare disease people, even more so. Because if there's only 300 of you in the world, you have to have the picture. You have to send the data and say, is there anyone else who has a child with this disease that we don't know what it is? So you can't have good science without some sort of solidarity and sharing of information. And you certainly can't have personalized medicine. So you get this conundrum between, I want my privacy, but I want better health care. And that's, I think, where we start our discussion on the future of Canada's healthcare system. We all know that people will go on and they'll send in their saliva to 23andMe and hope to get some sort of forecast of their future. I won't say more about this one. So I'm involved in a really big study with Jacques Simard from Laval University, and proud to have a colleague of his vision. And we actually have 85,000 data and samples from 65 studies in 30 countries. It's an absolute nightmare because some of the consents date way back. Some people, their samples, they're now deceased. Others, data cannot leave the country. So how do you, and this project is to see whether screening should actually be offered at a lower age if we can identify the subpopulations of high-risk women that would benefit from such screening, and actually screen, which is like a population kind of project, younger women who would be at high risk, and at 50, it's too late. So we've been working with, this is my colleague with Chadwick and I, every 10 years we write an article, we're writing another one now, about what other principles can we distill from the different ethics documents that will allow us to see where we're going in terms of our thinking. And you can see the difference between 1994, very individualist, and 2005 at the beginning of the whole population biobank idea as a resource. And now we're imagining or trying to do another article on what is out there in terms of values and ethics in 2014. So turning then to the conclusion, what kind of solutions are being developed that'll help us move forward? How do we make sure people can always withdraw from research, that their privacy, if they want it, in other words, not presume that everyone wants everything protected, but if you do, that you can, and what kind of oversight? And why can't we move the conversation to the benefits of research and medical care, not just the risks? So it's siloed, not only by discipline, but by ownership of databases. People get very, that's my data, my patients, my samples, my research project. We have to get out of that and say, if you have public funding and you're a researcher or a clinician, that the data that you're holding belongs not only to your patients or research participants, but actually to the healthcare system, to the publicly funded healthcare system. So we have to move out of our individualist way of looking at research. In 2007, Genome Canada, one of the sponsors today, sponsored P3G, the Public Population Project in Genomics and Society. And we created two tools. We created retrospective tools. What can we get out of the data that's already there across different countries by looking at comparable, harmonized data sets? Couldn't standardize them. It's too late. People were birth date in different order, body mass index in different order, height in different order. It was a mess. But we were able to retrospectively put together about a third of different populations going in limited data sets going back in time. Prospectively, for biobanks, we created tools, both ethical tools and epi tools and so on, that moving forward, biobanks across the world who used the core data set, the core questions, the core measurements, are now 63% interoperable. Why is this important? UK Biobank has 500,000 participants. Canadian Partnership for Tomorrow project, 300,000 participants. We can go on. Japan Biobank, Estonia Biobank. We need, even if you have 500,000 UK women, 500,000 participants, and you say, okay, UK Biobank, I need 10,000 women who have X. It would take them 13 years to give you that data set while they wait for more women to enroll. By making these interoperable, in 3 years, we can get that cohort of 10,000 women around the world. But we have to also create what's called data safe havens, accredited databases that meet certain criteria. When you go to an ethics committee or privacy commission and you say, this is it, this is my project, and I will put my data in X, safe haven, then it's known that that is secure. The data is going to be used in a responsible, accountable way. So it's too small to read the criteria. This is an article that was submitted last week, and I'm not even sure I can read it, but data maintenance and release must be socially acceptable and appropriate. It must be veritable, and it must be safe and secure. And we've submitted a list of criteria, but we don't know if it's going to be published yet, so don't take pictures of this slide. We've also created, as a follow-up to P3G, an international sort of policy think tank for people who want to say, can we work together? Sweden, Japan, Ghana, and Brazil. And are we interoperable? The consents were just, we did it all separately. Now we want to work together. So we have what's called an ELSI, interoperability service, that we offer in my center at P3G. And we have a data access committee that looks and gives authorizations to researchers to, for instance, access the International Cancer Genome Consortium database, which is in Toronto with Tom Hudson. And so we authenticate the researchers, we check their bona fides. You'll remember there were 2 German ministers of state who actually lost their positions because they had lied about having a PhD. I mean, you have to know that the researcher is who he or she says she is and has the proper credentials, security, ethics clearance, and so on. So my 10-year project is to do something streamlined, simple, and interoperable for ethics committees. It makes absolutely no sense. They're like little castles with moats around them. And then you have a project across Canada with 17 hospitals, or you have, something with the number of countries that I was showing you earlier. And you can spend, out of a 3-year project, you could spend 2 years before you even Cartagena. Half of the 3 years we had to build it were spent getting ethics clearance, and then we had to rush the science through in the last year. It's untenable. It cannot work. We have to get a new system, and we're thinking about creating a safe harbor. If I have time during questions, I'll address that. So my final few slides are about a new alliance. No money. A bunch of high-fluting thinking people got together a year ago in New York in a snowstorm and said, we've got all this genomic data. We've been doing it ever since the sequence map of 2003. But we're not going to get anywhere. We can't even do cloud computing. We're missing the clinical data. Where's the real people with the real conditions with the real data, in addition to the genomic? So we created the Global Alliance for Genomics and Health. And the first tool that we did is this framework for responsible sharing of genomic and health-related data. This framework has been translated into 5 languages: Arabic, Japanese, Chinese, Spanish, and French so far. We're heading for German and Greek and I don't know what else. What's new about this? This is not your typical bioethics declaration or UNESCO or whatever. No, this is built on the Universal Declaration of Human Rights. Signed and ratified, the article that we're basing this one on, this framework, in 1966 by 162 countries, an international convention that took the Article 27 of the Universal Declaration, the right of all citizens to benefit from the progress of science, and the right of those who contributed to it to be recognized therefore. So the right to benefit and the right to be recognized, i.e. the scientists, thinkers, or whatever. So this is a human right. It's in a convention, which means it's politically actionable. And that's where this framework hopefully will make a difference. So getting back then to the healthcare system, if you look on the left, you see all kinds of data that they use to figure out, environmental risks and so on in terms of census and transportation. If you look on the right, you see all the ohms, symptoms, and microbiomes and genomes and individual patients, and you look at this layering. Similar ideas of what we need. And here you can see that if we could create health data hubs where all the data that's now siloed in clinical trials, in hospitals, I forgot to add a little circle for healthcare like RAMQ in Quebec, the insurance OHIP here in Ontario, registries, biobanks, research industry, and actually have a systems approach to the collection and use of data. So a common, user-friendly space where even patients or citizens could contribute data. This is, I think, probably the same thing done in another way, and it's probably unreadable, but on the right you can see clinicians would have up-to-date knowledge, patients would participate, policymakers would have better information for regulatory reimbursement, researchers would have clinical relevant stuff, industry would be faster, cheaper, more successful, services would be provided, and so on. All because data and specimens and so on are collected and centralized. So this is a simpler version and more readable. Traditionally, you come up with an idea, then you wait for money and a project, and you experiment, and then you have your conclusion. This is different. You go to the data now, and then you form your hypothesis. And it's only possible to have good hypotheses with good science if you have the contributions of the health apps, the Fitbits, the genetic tests, the genomes of your family members, census, all kinds of lab tests, and so on. So, in conclusion, I come back to network theory. And it's good because systems can only work with an approach that realizes not only the complexity of networks, but also the very simple solutions, hopefully, that lie therein to make big data a real innovator in healthcare systems, but I would say not a guarantee of its sustainability, but a step that we should take towards using it to make sure our healthcare system is innovative and sustainable and universal. Thank you.
Thank you very much, Bartha. I feel like you're our safe haven this morning in bringing us through that. I'd like to now invite Cindy Bell, who's the Executive Vice President at Genome Canada, to thank our speaker. And we'll then move on into the Q&A.
Thank you. So I think you gathered today that Bartha is clearly a big thinker. But not only is she a philosopher, but she's a practitioner. And Bartha has really been instrumental in acting on many of the things that she talked about today. She was there when the Human Genome Project was underway, leading initiatives to define principles and policies and practices that needed to be put in place. And she came together at the partway through that, recognizing that Canada did not have their own Human Genome Project. We were not around the table during that initiative. And they worked together, Bartha, a number of other scientists who were visionaries, as well as visionaries of federal funding agencies here in Ottawa, such as Henry Friesen. And they convinced the federal government to fund a fledgling not-for-profit called Genome Canada. And since that time in 2000, science that has gone on across Canada because of visionaries like Bartha has created a lot of this big data. And we are so thrilled that Bartha is still one of the stewards of that big data and ensuring that we are going to make the best out of what we have funded, what the government and other partners have invested in, what scientists have worked to make sure happens, and what the public, the patients around the world and in Canada have contributed to ensure that we learn from them and eventually benefit our healthcare system. And so I think we really need to understand Bartha's role in that. And she's been recognized by the Government of Canada and Order of Canada for that. And I would like to ask you to really recognize her contributions today because it's much more than what she presented in her brief talk. So thank you. Thanks, Bartha.
Pleine, mais on a du temps pour les questions. Le micro est là. We have time for questions. The microphone is there. Just two rules. The first is that you identify yourself so we know who you are as you ask your questions to Bartha. And the second is because we are in Parliament, 30-second rule. House of Commons rules. You can only have 30 seconds to ask your questions. So, the floor is open.
Bonjour, mon nom est Denis Blanchette, je suis le député fédéral de Louis-Hébert. J'ai bien compris l'intérêt de pouvoir avoir des données qui sont agrégées pour être capable de tirer des tendances et tout ça. Mais évidemment, pour être capable de faire ça de façon durable, on a besoin de confiance. Vous l'avez abordé de façon accessoire quand vous avez parlé de bases de données sécurisées. Vous avez utilisé l'expression safe havens. J'aimerais savoir un peu plus comment vous avez travaillé cet aspect-là de garantie de confiance que les gens, que les hôpitaux, que les médecins, que les patients ont besoin pour assurer que les données soient disponibles à long terme pour le bénéfice de tous, mais évidemment, tout en les gens en ayant confiance que ça puisse continuer de façon correcte.
D'accord. Ça n'existe pas encore, sauf en Angleterre. C'est une idée qui vient des Royaumes-Unis, où le NHS, leur service national de santé, a décidé que pour vraiment faire le pont entre cliniques, hôpitaux et bases de données de recherche, les chercheurs sont habitués à cette notion de contribuer, puis ensuite il y a des audits quand même, il y a des conditions, comme j'ai dit tout à l'heure, avec des comités d'accès qui vont évaluer les chercheurs, puis que leur projet puisse rencontrer toutes les exigences à la fois de la loi ou de l'éthique scientifique. Là, ils ont fait le saut, c'est-à-dire qu'ils ont décidé qu'on pourrait pas avoir une intégration système de santé donné avec système de recherche donné sans cette notion de safe havens. Donc, ils ont commencé à construire ces caractéristiques que j'avais mises sur le diapo, sont beaucoup plus détaillées que j'ai pu annoncer. Et ça vient après 5 ans de recherche avec des consultations publiques exactement. Parce que on a nos commissions d'accès, mais ils sont pas spécialisés dans des données médicales puis scientifiques et tout ça. On a des comités d'éthique dans les hôpitaux, mais eux, c'est surtout de protéger, etc. Et on a nos chercheurs qui, avec manque d'accès, la qualité des données, l'utilité des données n'est pas suffisant. Et on a des cliniciens qui sont encore dans le monde, comme les généticiens étaient, ou les génomistes, je sais pas si c'est un bon français, ça, il y a 10 ans, avec ce mes données, etc. Donc, avec ce safe haven, au labri, je sais pas comment on va l'appeler en français, il va falloir trouver un nom, on crée cette confiance-là, que les participants, qu'ils soient des patients ou des participants dans la recherche, dans les essais cliniques, savent dès le début, et les chercheurs, et les comités d'accès, etc., et d'éthique, que là, c'est sécuritaire et il y a un audit, une surveillance continue de ces données-là, mais qui soient utilisées aussi et utilisables.
Hi, I'm Sharon Hamilton. I work with the National Cybersecurity Directorate within Public Safety. So obviously my question has to do with cybersecurity. Healthcare records have an enormous value on the black market. And in the last year, some estimates I've read have said that hospital hacks have gone up by 600%. So when I hear you talking about bringing data together, I guess what I hear is, wow, that's a big target. So I wondered if you could talk a little bit about how the international conversations in particular are addressing this particular issue, how to protect the data once you've managed to put it together.
Thank you. The Canadian Council of the Academies is actually doing an assessment right now, and I happen to be part of it, on access to linkable, usable, and safe data in our new cyber world, and I know it's been discussed in Parliament this week as well. The idea then in terms of sharing health records and making them accessible for the public good as opposed to hackers and perhaps even illegitimate commercial interests, I think is a really important topic. The way data is shared right now, it used to be just via computers, but the data sets are too large, which is why we're now turning to the clouds. Clouds, there are private clouds, university clouds and so on, but the size of data, the volume, means that most of us are looking at commercial clouds. So again, what do they offer? And I said, no, but how people, they will not have faith in this new way of doing research via the cloud unless they know that there is some thought being given, real thought and real mechanisms for the specific character of health data, which we need, which has to be accessible, but which has to be not only really protected, but be seen to be protected. So I'm not put locks on everything and then, the public will be secure, but nothing will happen. We have to find ways then to make these commercial cloud providers realize the importance of being able to share data. Look at Ebola. I can tell you right now there are researchers sitting on data that is in the public interest and is very important for public health and one is because they want to be the first to publish, again, or because they simply are scared if they start using and sharing that someone will extract it, hack it, and then misinterpret it and scare the public. So it's a really delicate balance of all those considerations. But I spend my time in cloud computing contracts. I thought I'd never have to do this, but that's where we are right now.
My name is Rule Amder, and I write for Canadian Charger. My question is, what do you see the possible loss that has occurred because of abolition of the long-form census?
Oh, I love the long-form census. I'm not even an epi person or officially a public health person, but what a treasure trove that was, and how important it is for healthcare planning and programming, and sort of like a Lament for a Nation. I'm sure you remember that book. So I won't comment further on that. I did want to say, I didn't finish on the last, there was something still turning somewhere. The Nuffield Council on Bioethics in the UK commissioned for over a year a study on breaches in healthcare data. Other than some tired physicians leaving their computers in their trunk, or some super sophisticated who call themselves friendly hackers who want to show that the system is fallible, they were not able to find documented, validated cases of breaches in health research of data security and privacy. So I think we'll have to make sure our Council of Canadian Academies gets a hold of that report ahead of time, because it's really important, because everyone thinks that everything is hackable and accessible. And as I said earlier, maybe, remember the 14-year-old from Dorion in Quebec who got into the, I think it was CIA computers about 15 years ago? But that's not how you make policy. We know they're out there. And often the hackers, they'll publish afterwards, believe it or not, and then they'll tell you how they got into your system and how you can make it better. Those are the so-called friendly hackers.
Wendy Watkins, I'm the data librarian at Carleton University, and we are arranging training programs for graduate students in data sharing and data management. And then we run into ethics boards that don't understand data at all. And so we have this kind of kind of thing at the university, at the administrative level. We're wondering what Genome Canada might have to teach us about both the training of graduate students and researchers and of ethics boards.
I'm almost at the point now where I think the current composition of ethics, as mandated by the Tri-Council Policy Statement of the ethics committees with their multidisciplinary composition, it isn't enough to put a bioinformatician or a privacy-savvy person to transform your ethics committee into a committee that can understand how data works, how data needs to be managed, how to access it, securely use it, and so on. I'm not saying we should create another committee for poor researchers to go through, but rather I think this safe haven approach, once these databases are accredited as safe havens, we build a system. It shouldn't take long. We can say in our consent form and tell patients your data will be deposited, tell ethics committees your data will be deposited, and then we will know that there's a system in place to protect data, and it's built by people who understand data management and data use and so on.
I'd just like to take the prerogative of the chair to ask one question as we end. Bartha, seeing things both from the perspective of genomics and the law, but also in the policy environment, where is the blocage? Where do you think are the biggest challenges in being able to move towards a safe haven approach? And are there lessons from elsewhere, apart from the UK, that can tell us what to look out for and what we need to do better?
I'll answer the last and then the first. I like Denmark, talking about long census, and they have registries, and everything is in Estonia too. You go in, you have a number, and then they know, from the cancer registry, the mortality registry, and the school. They are organized to help as a society your data together with all that of other citizens to really construct their roads, their schools, their hospitals, and so on in a way that reflects real lives of people in communities. So I am one for a more data-rich and data collecting and long-term data to help us build a better society. What's missing? That's just one word: trust. I think that's it. That's the key. If you don't have trust, patients won't let their leftover little, 4 aliquots of blood or mLs or whatever they're called be used. They won't let their data be used, and so on. And researchers won't share, and clinicians certainly won't get into the new philosophy of putting their data out there, which isn't theirs, it's their patients. So trust.
Thank you very much.
Welcome.
I thought that was a brilliant presentation. Thank you very much, Bartha, for bringing the question of big data and the transformative potential of it to our attention, but also in helping us to understand how we navigate this brave new world and how the things that you do, the people in this room here in Ottawa, matter. And will have an impact on the future of how this data can be collected, shared, and potentially have an impact in our lives through our healthcare system and in other ways as well. So I'd like to thank you again, Bartha. I'd like to thank Genome Canada for working with us, for Cindy Bell for being present, to thank our speaker. We're very grateful for your support. Merci encore au Conseil de recherche en sciences humaines pour leur soutien précieux aujourd'hui et tout le long de cette série. J'aimerais aussi encore remercier James Rajot, notre député parrain de la série Voir grand. Et c'est grâce à James, comme j'ai dit, que ces événements peuvent avoir lieu dans ce magnifique restaurant du Parlement. And I'd like to invite you to our next Big Thinking lecture series. We're taking it on the road. And we'll be having our next lecture in Quebec City. Au Fermont-le-Château-Frontenac, and there we will have Shauna Poplak, who's the Canada Research Chair and Professor of Linguistics at the University of Ottawa, who will speak about myths and science, the ideology of standard French. So that's in Quebec City on November 21st. Merci encore d'avoir été avec nous en si grand nombre ce matin. Merci beaucoup et bonne journée. Have a great day.